A very good afternoon to you all. I am Rabbi Darko, and I'm going to be your moderator for today's Psychologist webinar. We have a few minutes to get to 2, so we could start. So I'll admonish that if we can share the link to our friends in our various groups, so at least we could have a large audience for today's webinar. So very soon we're going to start. Thank you very much. Listeners, good afternoon to you once again. It appears the time is 2:02 and we can start. Yes, so if we can keep on sharing the link to our friends and our various WhatsApp platforms so that at least a lot of them can join, we will be grateful. Yeah, today's program is brought to you by the KNUST Wellness Center in collaboration with the Behavioral Sciences Department of KNUST and the KNUST Counseling Center. This has been a program since we started last year. We've been educating the university community on psychological issues and problem mental health. And today we're going to delve into autism and its management. And to help us sail through this important topic is Madame Dorcas Owusu. Forgive me, I don't know whether she's Mrs. or Miss. I think she will tell us that aspect when she starts. And I'm aware she's on the platform. So once again, you welcome Auntie. Dorcas Owusu, a little bio, is a dedicated and experienced psychologist and behavioral therapist with proven success managing psychological issues or problem and behaviors with psychotherapy. She currently works with the Konfuanoti Teaching Hospital as a psychologist there. And she helps in administering psychotherapy to clients. She provides care and support to people struggling with alcohol and drugs to overcome withdrawal symptoms. She also provides psychological care for abused children and train intense and practical students. I think prior to that, she became a psychologist assistant at KATH, and you could realize that she mostly worked with children with special needs for school placement. She also educated clients, careers on mental health and childhood disorders and how to manage them. So you realize that she's well-versed in this area. She attended Kwame Nkrumah University of Science and Technology, where she did her MPhil in Disability, Rehabilitation and Development, and had his first degree at the University of Ghana, Legon, where she studied psychology. Ladies and gentlemen, kindly help me welcome Auntie Dorcas Owusu to sail us through this webinar. Thank you. Auntie Dorcas, the floor is yours. If you can hear me, please unmute and talk.
Hello, good afternoon, everybody. Please, you are all welcome to today's Psychologist presentation. As we were all told, I am Dorcas Owusu, psychologist at Konfuanoti Teaching Hospital, and then a behavioral therapist. Specifically, I manage children and everybody with challenging behaviors. So today we'll be talking about autism and its management in Ghana. I believe most of us have heard about the word autism. And in one way or the other, if we are to ask a question about the ideas and all that we know about autism, I know we can share our ideas and our views on it. So today's presentation, we will all get to understand what autism is, the origin of autism, and then how to manage autism, specifically in Ghana here. Thank you. Okay, let's go to the origin of autism. Autism is an English translation of a Latin word autismos, which was derived from the Greek word auto, which means self. The term autism first was used by a psychiatrist, Eugene Bleuler, in 1908. Bleuler was managing a client with schizophrenia who was having a symptom of withdrawal syndromes. And then he withdrew into his own world. He was not talking to anyone. He was always doing things and living by himself. So that made Bleuler come with the term autism or autism. And then in 1943, American psychiatrists made the word autism take a new form and a new dimension whilst he was taking over a period of 5 years. And then he observed their behavior and found out that they all had certain behavioral similarities. And then he came by the common term autism, which for autistic children, they live by their own self and they live in their own world. So Leo Kanner coined the word autism, making it to mean that children or people with autism live in their own world. What then is autism? Autism, as we are talking about, is a dyad. It has two sides or two elements that come together to make one term. And then the first part of the dyad is that children or people with autism, they have disturbed reciprocal social interaction and abnormalities in verbal and communication. Verbal and non-verbal communication, sorry. And then they also have restricted, repetitive interest and then sensory disturbances. So autism is a neurodevelopmental disorder. It's a neurodevelopmental disorder. When we talk of neurodevelopmental conditions that affect the functioning of the brain. So we have a lot of neurodevelopmental disorders. We are not talking about them today. So our focus is on autism. So autism is part of neurodevelopmental disorders. And the characteristics of autism are, the first one is persistent deficit in social communication and social interaction across multiple contexts. So children with autism have deficits in communication, deficits. And then a person can also...
Yes, it appears we are experiencing some breakages. So respectfully, if I do not know if you can put off your camera, maybe that can improve the internet connectivity. Yes. Please, do you have slides, respectfully?
Okay.
I
wanted to share the slides with you. Yes, I have the slides here.
So I don't know if you can share it with me so I could see if I could project it here.
That would be good.
Yes.
Okay, thank you.
Thank you too.
Sorry, let me share the slide. Please chat me with your number so that I can share it, or email address.
Okay. Let me see. So my number is in the chat box. I've sent it.
Okay. I'm sorry about the breaking transmission.
Okay, don't worry.
I'll be back soon.
I think it's better though, just that let's share. If we share, members can really appreciate the content. E-learning and co-host, please, can you allow me to share? Can you give me the permission to share, please?
Okay, please, I've sent it to you. Thank you. Okay. Can I continue, please?
Please, hold on. I'm also working on that. If you can hold on a little.
All right.
Yes, so, yes, I've seen it. I'm working on it, downloading. Please, can members, please, can you see?
Yes, we can see.
Please, I think you can. Okay, Dorcas. Yeah, please, can you see?
Can I?
Yeah, you can.
Yes, I can see.
Yeah, so you can proceed.
Okay. So I was talking about what autism spectrum disorder is. And so please, can we move to the slide, that slide? What is ASD? What is ASD? Yes, please, thank you. So autism spectrum disorder is a neurodevelopmental disorder with persistent deficits in social communication and social interaction across multiple contexts. So a child or a person with autism has deficits in social communication. The person here can have verbal communication. They can say everything they want to say, but they might have difficulties in communication, like having the flow in communication. And then another person too can have autism and may not have verbal communication at all. And that same person can also have communication or social communication deficits. So they cannot speak verbally, and then they cannot interact non-verbally. That is the first symptom. And then they also have restricted repetitive patterns of behavior, interests, or activities. You can see a child with autism flapping their hands all the time, and they become so fascinated about doing that. They become so happy doing that repetitively. And then they can arrange things in patterns. If they are in the house, you see them arranging shoes in a particular manner. And by mistake, if you find yourself disrupting them or destroying the pattern that they have created, they will have issues with you. They can throw tantrums and do a lot of things that will show that they are not pleased with what you are doing. And they may have interest in specific activities. Something that everybody might not be fascinated about might fascinate people with autism. And then the symptoms must be present in the early developmental period, typically from age 2 years and above. That is where the symptoms must be present for a person to be qualified to be diagnosed with autism. And the symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. So people with autism have social deficits, they have occupational deficits. And when we talk about occupational deficit, it's not about the work that they will do in the future. That's not about it. But what occupies their day? You see, every human being has things that occupy us in the morning or during the day: bathing, toothbrushing, activities of daily skills. So all these activities, my performing them might be a challenge of a child with autism. So that's what we call occupational deficits. And then important areas of current functioning, like being able to make good eye contact, and then staying in classroom, all these areas, they may have difficulty in engaging themselves in such areas. And then, please, the next slide. Some examples of disturbed verbal communication in autism. Examples of disturbed verbal communication in autism. Some of the examples.
Auntie Dorcas, we've lost you. Auntie Dorcas, can you hear us? Auntie Dorcas, can you hear us? Listeners, we are very sorry. I think we've lost Auntie Dorcas. We are hoping that she comes back. Please give her some time. We are very sorry for the inconvenience. I think she is back.
So sorry about the network challenge. And they have difficulties engaging with ordinary to and fro conversation. So specifically those with verbal, those who are vocal, you may ask them, how are you? They can spontaneously say, I'm fine. But then they can't flow in the conversation. They cannot ask you questions, meaningful questions, or they cannot proceed with any other answer that you require from them when you ask them questions. And then they have something that we call neologisms. They make up new idiosyncratic words. Like a child I have, he will call food gogo. That's how she calls food. Anytime she sees food, she says gogo. So if you don't know her and she comes to you and says gogo, you wouldn't know what she's in need of. You just stare at her and she goes. So these are some of the communication disturbances. And then they have echolalia, that is purposeful repetition of words or phrases. sometimes long after hearing the word. So if you ask her, how are you? She also say, how are you? If you say sit down, they will also reply, sit down. They will repeat every word that you say to them. And those that repeat the words long after hearing them, when they are there, all the words that they have heard, especially in our setting, we see these children as being, in quote, problematic. So anytime they pick something, we say, put it down, stop it, put it down. So when they are there, you see that they will be echoing this word, sit down, shut up, put it down. That is what we mean by echolalia. And then they have pedantic language, that is unnecessary precision in speech. That is what they do. So if you say, and then they have literal interpretation of jokes and idioms. When you say right days of the week, they will also say, they will write right days of the week. They can't understand what you mean by saying right days of the week, or list the items in the box. You give them items in the box and you ask them to list items. They will also say list item in the box. That's what they will write for you. They can't have that understanding or interpretation of what you mean by write this or do this. And in severe cases, there may be little or no verbal language. That is mutism. Children with autism can be non-verbal at all. And in our setting here, I think that is the prevalent one. So far, though most of the cases that have been coming are the ones that are non-verbal. Most of them don't speak at all. And then they exhibit the above symptoms too. Please, the next slide. Some examples of disturbed nonverbal communications in autism. So aside having verbal communication deficit, they also have nonverbal communication deficit. And they don't understand facial expression. When they are doing something and you are displeased, and then maybe you frown, they don't understand it. They'll just look at you as if nothing has happened. Nothing scares them, nothing moves them. They don't understand the facial expressions. And then they cannot point to explain things. When they are going or when they see something that they are familiar with, they can't point at it to show you that they have seen this or that. That is one of their nonverbal communication deficits. And then nodding for yes or no, they don't understand that one too. Shaking your head for no, nodding for head yes. When they are doing something and you shake your head to show them that they should stop, they don't understand that one. And if you want to approve of what they are doing by nodding for yes, they don't also understand. They might also repeat that same activity after you. And then they have conventional gestures. They don't understand conventional gestures, like finger to the mouth to mean silence. If you put your finger on your mouth to show that they should be silent, they will also do that after you. Or they will not even recognize the importance of what you are trying to mean at all. And then imaginative or pretend play. You see, every child growing has this skill of having pretend play and then imaginative play. When we talk of functional pretend play, taking a stick to represent a spoon. You see, when we were children or children growing up, they can take items to represent other things. When they see something that is molded in a rounded form, they can use it as ball when it is not ball. When they see a stick, they can replace it as spoon. They can mold certain things into the shape, so they can replace certain items to represent other things. And then also, children can also know the function, the actual functions of items around them, like using spoon for feeding and other things, so for bathing. But a child with autism can pick the spoon and then be hitting it, doesn't know the function of the spoon. And then whilst playing, they cannot have that pretend play, like taking a stick or a comb to represent a baby. They don't have that skill. And non-social play, example, peekaboo. If you are with a child with autism and you say, okay, let's play hide and seek, you go and hide, they will not search for you. You stay there so that kingdom come. They don't care. That is some of the deficits. And then please, the next slide. Restricted and repetitive interest. They have unusual, intense preoccupation with obscure subjects like dinosaurs and things that are obscure, things that doesn't drive anyone's interest. These are the things that they want. They are always interested in obscure objects. And then they have inflexible routine, intense desire for sameness. Example, if you have a child with autism, and maybe you take a particular route to school, from home to school every day, and then one day you want to pass by the shop or somewhere to buy something, and then you change your direction or you change your route, they will not be happy about it. They always want the same thing done every day in the same way. That is one of their repetitive interests. And then they can line up toys, as I said earlier, in a non-functional manner. They can line up things, sandals, shoes, chairs. You see them always lining up things in a non-functional manner. They will just be doing that repetitively every day, every time. And if you find yourself interrupting with them, their activities, they will have issues with you. And they have challenges with, they have obsessive behavior in autism. Obsessive behavior in autism can confuse itself with OCD. Those in the mental health field will know OCD, obsessive compulsive disorder. And what we will say about this is that OCD and the obsessive behavior in autism are different. Children with autism repeat activities and routines with fun. They do it to boost their ego. They do it with joy. But people with OCD, obsessive compulsive disorder, they do it under compulsion. They are not happy about what they are doing, but they still do it. So please, let's not confuse ourselves with OCD and then obsessive behavior in autism. And then other features of autism. Please, the next slide. Children with autism may have problems or challenges with touch. They may get upset when you touch them. Some of them don't want you to touch their ears at all. Some of them don't want even the feel of shaving the hair. So most children with autism have challenges with shaving the hair or going to the barber. Because when they go and then they set the machine, that sense of brittleness in the machine puts them off. It gets them, it makes something happen to them. So they don't want that feel at all. And then they have sensitivities with texture. Some of them don't like certain textures, be it muddy, sticky, watery. Each of the symptoms or individuals with autism have their different or specific textures that they don't like. And then when it comes to sound too, some of them, you see that they cover their ears whenever they hear a high-pitched sound or a particular song that plays. I have a child that, interestingly, she doesn't like the sound, happy birthday to you. Anytime she hears it, she will cry. Even if you play the tune, and she will cover the ear and scream loud, please, please, please. She doesn't want it. But the sound that she likes so much is Sansan Chroma. Sansan Chroma is what amuses her or fascinates her. So that is for her. And then some of them too have sensitivity to some food. You have a child with autism who would not take any solid food at all. They will not take solid food. All that they would want to take is liquid. And we have others too who wouldn't want to take liquid food, but also they will take solid foods. These are some of the symptoms. And other features, please, the next stage, the next slide, please. Self-injurious behaviors. A child with autism can be banging the head to show displeasure or for fun. So it depends on the reason for that behavior, unless we assess and find out what's really causing that. But you see a child with autism always banging the hair, hitting the hair, biting themselves, biting their fingers, causing harm to themselves. And then they have that hand flapping, hand twisting, and then some abnormal gestures of the body. That's what they do. And they are most often preoccupied with particular body parts. So you see that a child with autism will be working with the mother or always will be attached to the mother. Not that she likes the mother, but then a particular part of the body, of the mother's body, is what they might be attached to. Let's say the soft part, their breast or their underarm, that is so soft. You see that they'll be so close to their mothers, and then they'll be just playing with those parts of their body. You see them that they are with an object, and then they are always with the object or that a particular toy, and they are not so much interested in the toy, but a particular part of the toy is what fascinates them. Or maybe a sound, a buzzing sound that the toy makes is what fascinates them. So you see that they are always with it. They will repeatedly be shaking the toy to hear that particular sound. That is what they do. And please, the next slide. Autism is not always negative or scary in quotes as we might think. We have some positive parts of autism. We have positive aspects of autism. And children with autism, they are very creative. The fact that they might not be functional in their ADLs and some aspects of their lives, they might have deficits in their social and communication skills. They can be very creative in a field that they are interested in. If this is what they are interested in doing, give it to them. They will do marvelous work in it. And then they give detail oriented. They are detail oriented. When you are showing them something, they will make sure that they get to the detail of the whole thing. Let me see, a child with autism can be fed at 9 o'clock a.m. every day. That is 9 a.m. And this child will wake up in the morning, will not look at the clock that everybody will do and say that, okay, it's 9 a.m., let me go and eat. The child might not look at the time, but will know that it is 9. They will come and request for the food. And when you check the time, you see that it's 9, exactly 9. That is how they are. They do fantastic in that. And they are very innovative. They are loyal friends. They have a lot of positives in the slide. I hope that you are all seeing. They are very loyal. They will not deceive you. They will not disappoint you. And then they don't take advantage of others. What you don't like, they will not do to you. Even if they are holding something and you take it from them, they will not fight you for it. They are very peaceful individuals. That is for you, people with autism. And then they have great long-term memory. Something you teach them today, they might take notice of it so many months or years afterwards. They have great long-term memory compared to other children on with neurodevelopmental disorder. They are very, very good at keeping things. And then they love nature. They love nature so much. When you take them to sites that they will get the chance to jump and then feel nature, they are always happy about it. They are very hardworking too. Children with autism are hardworking. When they know the task that they have to do, exactly the time, they will make sure they do it on time. They will not play with their time of work when they are taught to do so. And then children with autism, they are good to keep as friends. You see, you can have a family that a child has autism, and the child might be so attached to a parent. And then there is that particular parent or sibling, they are so happy about them. Even if you beat them, scold them, or do whatever you want to do to them, they will still be loyal to you. They will still come to you. That is autism for you. The rest are there, so we can get them after the slide because of the time. And then, please, the next slide, epidemiology of autism. In the 1960s, the prevalence of autism was 1 in 1,000. That was in 1960s. And then it came to 3 to 10 in 1,000 beds. That in 2000, in the year 2000. But then with time, the prevalence has increased over time. And we are attributing it to better recognition and social media, publicity, and the awareness that we create, and the diagnostic criteria that we have now. So the prevalence has increased. It has really increased. And currently, from the Center for Disease and Control Board, it is 1 in 66. 1 in 66 births. And the prevalence is common among males compared to females. So as it stands now, if we have 5 children with autism, you see that 4 have autism and 1 will have, who have autism will be males, and only 1 will be a female. So it's very common among males. Please, the next slide. And then autism has no respecter of persons. It has no respecter of ethnicity, race, class, or whatever. If you have it, you have it. Whatever will make you have it, you will have it. It doesn't make choices like, okay, let's say all Africans. It's common in Africans compared to those in the Western world. No, everywhere you go, there are people with autism. So it happens in all socioeconomic classes. And as I said earlier, it's common in boys compared to girls. And it's high, there is a higher risk in children of older parents, especially the fathers. So if a man is older, is advanced in age, and then gives birth, there is a probability that they might give birth to a child with autism. The etiology of autism. Autism has no singular factor. It has no singular factor, known factor. And then the progress, there has been a progressive understanding towards the cause of autism, and tracing it to environmental and then genetic factors. And then the clearest environmental evidence in the cause of autism involves events before and during birth. So during pregnancy, what happens, and then at birth, what happens can be environmental factors to autism. And then I have this one here in the next slide. Advanced parental age at the time of conception. If a father is advanced in age, there is a probability that they can give birth to a child with autism. And then prenatal exposure to air pollution or certain pesticides. So if a woman is pregnant and they are exposed to certain pesticides and medications that are not prescribed, they can be contributing factors to autism. And then maternal obesity, diabetes, or immune system disorders in pregnancy can also contribute to the cause. Extreme prematurity or very low birth weight can also be a contributing factor to autism. And then any birth defects that lead to deprivation of oxygen to the brain. You see, there are some children that when they are born, they'll be asphyxiated, and for hours or days, and for a particular period, they might be deprived of oxygen into the brain. All these things can be contributing factors, environmental factors to autism. And then the biological factors are the risk is higher among relatives of affected individuals. As we all know, every condition, every disease, if a person has it in a family, there is a probability that other people in the family too might have that condition. That is the same with autism. So if a family or a relative has autism, there is a probability that in the future or somewhere around the corner, a person can also give birth to a child with autism without any environmental factors. It also occurs randomly. So it doesn't have selection that maybe this woman gave birth to a child with autism, so she will always give birth to children with autism. It occurs randomly. As I said earlier, it has no respecter of persons. And then there is no particular gene that we can hold on to and say that this gene can cause autism. No, it's not like that. There is no particular gene like that. And then a study reports that each subsequent child born into a family with an autistic child has 8 to 9% chance of having autism. So that explains what I said earlier on. And there is a twin study that also said that identical twins, if you have an identical twin that has autism, there is a probability that the other twin might also have it or give birth to a child like that, compared to that of fraternal twins. So it has that too. And then I have these facts about autism. Autism is a neurodevelopmental disorder with multiple etiologies. It has no single cause and it has no single cure. So unlike, let's say, malaria, that we know that, oh, malaria, you get malaria from mosquito bite. So when you are given anti-malaria, you will be okay. Autism is not like that. There is no single cause and there is no single cure. We have so many disciplinaries that help in the management of autism. And we have to bear in mind that autism is a lifelong condition. This is one of the things that when you tell parents, their hearts break, but that's the hard truth. And it's being lifelong condition doesn't mean that the state that maybe your child is in at age 5 will always be like that till they leave the earth. No, it is manageable. But then it being a lifelong condition is that maybe the child is having some behavioral challenges or deficits in performing ADLs at this time. And then they are trained and they are able to master that. That doesn't cure or take autism from their system. As they progress, as they grow, wherever they go, every age, every stage in time has its own symptoms and challenges that comes in with autism. That is what makes it lifelong condition. So a child can be functional, can do everything, but then they might have challenges with forming associations with others in their adulthood. That is what it means by being a lifelong condition. Assessment of autism. Please, the next slide. To assess a child for autism, there have to be a thorough evaluation by a team of doctors, child psychiatrists, child neurologists, developmental pediatricians, and the likes. They are all there to help with a thorough evaluation of autism. And as I said earlier, a reliable diagnosis is made from age 2. So before that, there might be signs and symptoms that might qualify a child for that. But then we cannot be so sure until the child reaches age 2 years. And then sometimes there is late presentation of autism, especially with report to the clinic due to the catch-up syndrome. Normally, what will alert parents to report of their children's condition, and then in the end they will be diagnosed with autism, is their delayed speech. So maybe a child is 2 years and he's still not vocal. They will say, oh, the father was like that. Or boys don't speak earlier. They will say that they will stay in the house. So by 5 years, the child will not still be talking. And then that will alert them to come to the hospital. And by the time they come, you see that it's not just delayed speech, but there are other developmental factors and then social deficits that were not taken into consideration. So the catch-up syndrome is one of the reasons that sometimes there are delayed diagnosis. And then for the assessment, we have clinical assessment. When you come to the clinic, we will take detailed history of pregnancy, birth, and then after birth, in the early developmental stage, what really happened? Was there any accident during pregnancy? Did the mother take any concoction, or did anything happen? So we take thorough history about pregnancy and birth. And then we come into the family to know of the family history. Then that will let us know or pre-inform us of our diagnosis. And then we do mental state examination for the children. We have behavioral checklists and rating skills that we use for all these assessments. So I have the screening instruments here, which are quite a number of them. So we have the checklist of autism in toddlers, the chart, we have M-chart, we have the STAT, that is screening tool for autism in 2-year-olds. And then we have social communication questionnaire. So if you come for diagnosis, it doesn't take a day for us to finish or for the specialist to finish with the assessment and diagnosis. We have to use some of these screening tools to screen the child to qualify, to make sure the child qualifies for a diagnostic instrument. So after screening them, and then we can use autism diagnostic observation schedule. That is the adults too, to help with the diagnosis. And so mind you, there is a difference between diagnosis and then screening. Screening, everybody can come for screening. If you have a child in the house that is not vocal by 2, they might not be autistic, but you can come for the screening with the above list. But when it comes to diagnosis, if a child has qualified or has had a higher score from the screening, that is when they will qualify for diagnosis. And then assessment continues. We have assessment domains. We have mental health or behavioral assessment. We have cognitive functions, how the child thinks or reasons, how they are able to, how they know their bearings and their boundaries in the house. Can they come back when they go out? Can they maneuver their way through in their environment? When you hide something, are they able to think after 5 seconds to know that you hid the thing here? These are some of the things that we check. And then there are coexisting physical morbidities with autism. So we have ADHD and other conditions that can comorbid with autism. And then you see that a child can be autistic, and then that child can be very hyperactive. So normally parents confuse autism with ADHD, then that might be a comorbidity with the ASD. And then we test for sensory difficulties, communication, family functioning, how they function in the house, and then how they function in the school. So we have assessment or assessment tools that we give to the school if they are at their school age, to give to their teachers to also fill those forms to help us get reliable findings for their condition. And then this will also continue with it. We have formal measures, adaptive functioning. We check for adaptive functioning, and then speech and language therapists will also do the speech assessment. We do social play therapy, and then the ophthalmologist will also assess the eye to see if it is really an eye problem or they are just not making eye contact. And then ENT, they will also assess the hearing to find out, is it deafness or it is autism. So we do all these things to be able to come up with the diagnosis. If we've known all these things, then how do we manage autism? Knowing that autism doesn't have one cause and doesn't have one cure. How do we then manage it? So if my child has autism, where do I go? How do I start it? Do I buy medication, or do I go to the OTC to get something for them? Okay, let's find out what we do or how we manage autism. And we have 4 goals for managing autism. The first goal is to help facilitate or stimulate the normal development of the child. That is their cognition and language and socialization. So when we come up with the management criteria, is to help stimulate their normal development. As we said earlier, it's a neurodevelopmental disorder. So we help to facilitate their normal development. And then we help to decrease the autism-related maladaptive behavior. That is one of the goals. We help to decrease the autism-related maladaptive behavior, like the tantrums, aggression, biting, the SIBs, all the self-injurious behaviors. We help reduce them so that the child can be functional. And then reduce coexisting but non-autism-related maladaptive behavior, like the ADHD that I spoke about. So when we are managing autism, we don't just say that they have speech difficulties, they have social difficulties, we handle them just like that. We also deal with other comorbidities, other conditions that comorbid with autism. We manage all of them together. And then to alleviate stress and burden for the family. It is not easy having a child with autism. So managing children with autism does not only concentrate on the children per se. We include the family too. We have therapy, psychotherapy for the families to help them, alleviate them of the stress-related symptoms. And then we help them to have the chance to also go to work and get something to put on table for the family. So these are the goals. And then because autism has no one cause and no one cure, we have a multidisciplinary team that takes care of children with autism. It's not one specialist, it's not one person that can do all the work in managing children with autism. First, we have the pediatrician, the neurologist, and then we have child psychiatrist. We also have speech and language therapists who also help with so the neurologist will help with the neurological aspects of the condition. And then child psychiatrists will also help with the psychiatric aspects like the ADHD and the likes. And then speech and language therapists will help with the speech and language and communication deficits. We also have occupational therapists to assist them acquire the ADLs, activities of daily living skills. And we have art therapists. By God's grace, in the whole Ghana, we have one art therapist who is at Confanoche currently, helping us manage these children with autism. And the art therapist will help with activities to help engage these children with autism so that they will not get more time to exhibit challenging behaviors. And they also help with the penmanship too, and the scribbling to help with the wrist, strengthening the wrist to prepare them for writing. And we have educational psychologists in various schools. Not all schools, some selected schools have educational psychologists and special educationists who help with managing children with autism. So when you come to our center or our clinic, we have all these guidelines or guidance for you, and then we can direct you to the places for you to get help for the children with autism. And we have behavioral therapists to help with dealing with challenging behaviors. That is what I specifically do. So let me say a few about what I do as a behavioral therapist. And behavioral therapy, please, the next slide. Thanks. Behavioral therapy is a highly effective management for autism spectrum disorder. It's very, very effective. That's why I said it's highly effective. The primary goal for behavioral therapy is to improve social communication and adaptive skills while reducing problem behavior. So you see, all these specialties or all these areas that were lifted above, behavioral therapists will help manage the challenging behaviors that interferes with the child's ability to perform all these activities. So we will help manage your challenging behavior to enable you improve on your social skill, communication skill, academic skill, adaptive skill, or any other skill that interferes with your daily activities. So that is what behavioral therapists we basically do. And then we have two types that we use in Ghana here currently, and that is the ABA, Applied Behavioral Analysis, or Applied Behavioral Therapy, which focuses on breaking down complex behaviors into smaller, manageable parts, and then whilst reinforcing desired behavior. So what we do as ABA therapists is that we break down complex activities or tasks into smaller and manageable parts. We don't just cramp you with the task to make it so difficult for you. So we have a way, I can't explain them all here. So we have ways of helping the child to be able to perform tasks without finding it so difficult. And one of the ways that we do is reinforcing the desired behavior while sometimes ignoring the challenging behavior to help them focus on the desired behavior. And then we have the positive behavioral support. This one too emphasizes on creating a supportive environment that encourages positive behaviors and reduces problem or challenging behavior. So we just manipulate the environment to make it welcoming or conducive for the child to exhibit positive behavior. So if a child goes to the classroom and is always crying, always screaming, we find out what is really triggering that. Why does he always cry when he comes to the class? So after doing the functional behavioral assessment, and then we find out the actual cause of that tantrum, we help to manipulate the environment to help the child exhibit positive behavior. And the techniques that we use in behavioral therapy is reinforcement. That is the first one, reinforcement. That is, we reward desirable behavior to increase the frequency of the behavior. But one of the problems that we have in Ghana here is that we are always particular about the challenging ones. What they can't do or what they fail doing, they are what we are particular about. But when they do something positive, we ignore them. So with ABA, we pay attention to the little things that they do, and we reward those behaviors to help them continue with those behaviors while ignoring the challenging ones. And then we have something that we call prompting. Let's say you have a child that is not vocal. You want to teach the child this simple thing that we always, how are you? I'm fine. So you ask the, and any other person will say, how are you? And expect the child to respond, how are you? We'll be looking at the child will not say anything, and they will go. But in behavioral therapy, we will prompt the child to respond every time we ask, how are you? So you say, how are you? In your voice, and then presumably in his voice, you say, I'm fine. So you do that spontaneously. So anytime you see the child, how are you? I'm fine. How are you? I'm fine. How are you? As you keep on doing that, it sends something to the brain. So they get to know that when you say, how are you? The next word should be, I'm fine. That is how we do. So we prompt them, and we have physical prompting, we have visual prompting, we have verbal prompting. So we have so many ways of prompting them to help them pass particular skills. And we have shaping. That is gradually building complex behaviors through reinforcement and promptings. So we help shape their behaviors. Let's say a child wants to dress up. They don't know how to dress up. You don't just leave the dress to them to wear. We have a way of breaking the task into smallest and simplest ways that will help them be able to do the activity whilst reinforcing them. And then our goal of using this reinforcement is not about the success of the activity that the child will achieve, but the effort that they will make in achieving the task. You can reinforce it to help them continue with that activity or behavior. So our focus is not on the success, but the effort. And then we have the chaining tool. That one too, we break down complex behaviors into smaller steps and then reinforce each step. So each step that you take reinforce you. As I said, it's not about the success, it's about the effort that you take. So gradually, as we keep reinforcing each step, we will get to the whole thing, and then everything will be okay. What can we do to help families too? As I said earlier, the focus is not only on the children, because if you are helping the children, we have parents and relatives who are also going through a lot in taking care of them. So the concern here, first one is lack of knowledge about autism. Most parents come without having any knowledge about autism. Let me pass this through. I met a parent that came, and then I asked her, what is wrong with your child? What did they say? What is happening to you? So she said that in Tree. Yes, me bano wenya orchis. I'm say orchis ni o say so wenya scam. And I say scam no e Okay, I didn't know the scam. So I started with the education. So as I was educating her and I started mentioning the neurodevelopmental disorders, and I said, autism. Well, see, yes, madam. Yes, when you or autism. So she has no idea about autism. So when she heard autism, what came into mind was autism. So what we do here is that we do psychoeducation on autism for these parents, and then we give accurate information on autism, the prognosis, the management criteria, what we have for them, everything that they need to know. We do education for them to help them raise themselves for whatever they have to face with their children's condition. And then challenging behaviors. If your child is always exhibiting challenging behaviors in the house, they are having sleepless nights and the likes, we train parents in behavioral management. So when they come for therapy, we don't just have the therapy session for the children. We train the parents too, because they are the people that are most often with the children in the house. So we're training for the parents and relatives to help them get to know the management skills for their wards. And then we have medications too that the psychiatrist and then the neurologist can prescribe for the hyperactivity, poor sleep, and the likes. And then poor daily living skills and independence. Hence, need for constant or long-term care. So if a child is, let's say, 7 to 10 years, or even less than that age, has reached the stage that everybody thinks or they are supposed to be toilet trained and they are not toilet trained, it's very, very, very alarming for the parents. So we give respite. We have places that provide respite care for parents so that they can leave their wards and then they can have time to go and then work. And then those who are taking care of them will also have a feel of the poo and the likes in managing all those things to help the parents also get the respite care. And also financial support. For the financial support, currently, we have a support group for mothers. And once a while, people do donate, and then the parents are fortunate, and then they get some cash in their pocket to help manage their children's condition. And then breakdown of parents' mental health from despair and desperation. Taking care of children with autism is not easy. Parents easily break down. And then they cry a lot in their closet. I did research currently on the experiences of parents in caring for children with such disabilities. And then it was found out that parents go through a lot: stigmatization, stress, burnout. Some even have come to the point of being suicidal. So with that, we give practical help for parents. We have respite for them. As I said earlier, there are institutions that you can go and leave your ward, and then after some, go and pick them. And then the support group that I said to, we have support group that parents will meet, siblings and families, they will meet and then share experiences, so that parents will know that they are not the only ones in the hood. They have other people who are also in it, and there are more people to also join them. So that helps with their management of stress and then depression in the condition. And then specific treatment for parents. Example, for depression. If a parent is found to be depressed as a result of the caring for their children with autism, we don't leave them like that. If it is manageable with psychotherapy, we do give them that psychological care. And those that need medication, we do refer to the psychiatrist for proper medication to help with managing the condition. Stigma from the public and even family members. Public and family education on autism, as we are doing now. So you have heard it. You can also tell someone that autism is not a communicable disease. And then children with autism are also human. So as we keep spreading this information and then giving out this education on autism, it helps to reduce the stigma on parents and then families of children with autism. What are some of the benefits of psychoeducation for parents with autism, with children with autism? The psychoeducation helps improve their understanding of autism. It helps improve their understanding. And it empowers affected parents and their carers, siblings, and extended family. So when we do psychoeducation, it empowers the family and relatives to be in good standing to take care of their wards. Please, the next slide. And then it helps to create more realistic. It helps to create realistic expectation for parents. Please, the next slide. So it helps to create more realistic expectation for parents by allowing mourning and adjustment. So when we do the psychoeducation, sometimes the parents are newly told. They are just made aware of their children's diagnosis, and then it's not easy taking that thing in. So the psychoeducation helps them go through their mourning and then adjustment procedures to brace themselves with condition. And then benefits of psychoeducation is it encourages advocacy by parents. So if the parents has been given them psychoeducation about autism and then its management, it encourages them to also advocate for children with autism. Wherever they go and they see people being stigmatized towards families and relatives with autism, they can stand in and then educate people for them to understand the issue of autism. So they become parents experts in the condition and then its management. And it prevents exploitation. It prevents exploitation. It protects parents against investment in non-evidence-based and potentially harmful treatments out of ignorance and desperation. It will marvel you that most parents that come to the hospital, by the time they get to the hospital, the amount of money that they might have spent in visiting the shrines and those prophets in quotes who are not, who don't have any evidence base in managing this condition, you will be amazed. So if we do the psychoeducation for the parents, it helps prevent that so that they wouldn't go and then get exploited by these people. And then we have medication. that can help with autism. But let's take this. There is no medication that can cure autism. Somebody might say, oh, if you come, autism, we will not come again. Please, it's not true. There is no medication for autism. But we have medication for the symptoms or the comorbidities of autism, especially if there is hyperactivity. We have medication to manage hyperactivity. That one, the psychiatrist will prescribe it. We have clonidine, medications, and the likes to help with the management of the hyperactivity. And when there is some challenging behaviors, there are medications to help calm them down or manage the challenging behavior. So we have medications that help with managing the challenging behaviors like risperidone and then aripiprazole. That one, the psychiatrist will prescribe for them. And then when there is depression and anxiety and obsessive behavior in the children, there are medications to also help manage them too. And then we also have melatonin for the sleep disturbances. That one, all these medications are prescribed by the psychiatrist. Okay, the learning outcomes. I hope by now, majority of us have been identify some of the core symptoms of autism, ASD, diagnostic criteria. I hope by now, when we talk of autism or when you are asked a question about what autism is, you can give some of the core symptoms, and then you'll be able to discuss the epidemiology of.
Auntie Dorcas, yes, so I think he is almost done. It's very unfortunate we are losing
The network.
and our time too is fast spent. Auntie Dorcas, can you hear us respectfully? Auntie Dorcas, can you hear us?
Yeah, hello, I'm here.
Yeah, so thank you very much
Yeah,
for
Mr. Rabbi.
yes, thank you very much for the presentation. We are so grateful. I think you are done. I think it was so insightful and detailed.
Yeah, I'm done.
Good. So, to our participants, any question for Auntie Dorcas, please? Our time is fast spent, so if we can speed up, I think she's here to help us deal with any question that may come up. So please, questions, Q&A sessions, please. The floor is open. If you want to talk, please you can put in the chat box or raise your hand. I'll give you the opportunity to ask your question. Yeah, Auntie Dorcas, I would want to ask my question. I realized looking at the continuum of support, or those key stakeholders who assist in supporting persons or children with autism, you realize that, as you rightly indicated, there is a multidisciplinary team, or there's a multidisciplinary approach in dealing with this. And you did mention that there's some amount of funds that is used to support parents who have children with autism. I can foresee that it appears to be expensive in treating persons with autism or trying to support them, because you would have to pay the pediatrician, you have to pay the child psychiatrist, you have to pay the speech therapist, the art therapist, all these key stakeholders involved. Is the money given to them enough to cater for these expenses? Thank you.
Okay, thank you for the question. Unfortunately, it's not enough. And the funds are only available for mothers that we have in our support group. And then it comes one in a while. Yeah, it's not enough to cater. That's the real fact. Yes.
Wow.
Thank you.
And the Ghana, what do you call it, the National Health Insurance too doesn't cover? Does it cover?
It doesn't cover.
Wow. Then I think those of us in the profession should really do something about that. At least if we can.
Yeah.
And put
We have to come on board. All of us have to come on board to help.
I agree.
This.
Thank you. Thank you. Please, any other question? I have a question from Annaba. She says, please, what part of Ghana does it cover? Is there support for people in the north What do you mean?
Oh,
Okay.
as I said, like, I get what she's trying to say.
Okay.
As I said, it's for those in our support group. We try to raise funds. We get donors to donate to support them. That's what we do. And I learned there is a disability common fund at each municipality that if parents go to their municipal directorates, they will be told what to do to secure those funds. But I learned it's not even enough. Yeah, it's not even enough to cater for them. I learned it's 3% for the whole disability cases in Ghana. So autism might have just a peanut. Yeah, but for our own, it's for the support group that we have at Confanoche. So if you are a member and the funds come, we just recently, I think in the Christmas, we made donations to them and they were happy. Yeah.
Thank you. Thank you. Another one, maybe the last one. When you observe your child has the symptoms, where is the first place to report or send a child? From Bernice.
Please, the first place to report is the hospital. You go to the hospital, report the symptoms, and then they will refer to Confanoche or whichever place that they have a pediatrician or neurologist or any of the multidisciplinary team members. They will refer for the appropriate management. Please don't take them to the home doctors and those people around. You just report to the hospital, the nearest hospital, and then you'll be sorted out. Thank you.
Thank you. Thank you. Listeners, we would want to say a very big thank you to you all, and most importantly to Auntie Dorcas Owusu for your time. We are so grateful for the detailed presentation. In fact, you've elucidated us on a lot on what autism is. You've brought a lot of stuff on board, a lot of revelations, and we are so grateful. Thank you for your input, and we are looking forward to having another engagement with you. Listeners, this program is brought to you by the KNUST Wellness Center in collaboration with the Behavioral Sciences Department at KNUST and that of the KNUST Counseling Center. The Wellness Center hosts a lot of programs. On Saturdays, there's what we call Saturday aerobic walk and aerobics, where members of the university community and those around, whether staff or non-staff, come together to walk around the university campus and also do aerobics. It's free of charge. It's a whole community. We treat and encourage everyone to pass by. This Saturday, we are coming, and it's just so enjoying. We come, we collaborate, we exercise, we enjoy, and we socialize. So try as much as possible to pass by. There's a dietitian at the Wellness Center every Wednesday who sees to staff. It's free of charge. Just come, talk to her. She will explore you and tell you or give you counseling as to what to eat, what to reduce, the amount of food to eat, or probably what not to consume, and even the quantity. Just come to her and she'll help you. And every Friday, there is a psychologist there as well. Yes, the counseling center is there. You can go there, but if you want to see a psychotherapist at the wellness center, you can come to him on Fridays. He's there to provide support for you. Once again, we are grateful to you all, and on behalf of the chairperson, Professor Ibokodro, we want to thank you all for joining. Thank you all and have a wonderful day. Bye-bye.